arthritis is extremely simple. You're going to say everything because we know everything about autoimmune disorder. This is an autoimmune disorder, multi-system involvement, predominantly joints. You can have rheumatoid skin nodules, you can have rheumatoid vasculitis, many things can happen. Please don't confuse this and rheumatic heart disease. Totally poles apart, fine? So this is an autoimmune disease, multi-system involvement, but primarily affecting joints. Okay? Primarily affecting actually small joints. Small joints are more affected than the larger ones. Okay? Clear? Autoimmune disorder. Put your pens down. You guys know everything about it. Genetic risk factor, environmental modification, T cells came in, caused destruction, produced a new antigen, had an antibody, going to use the antibody for diagnosis, rheumatoid factor and antibodies to citrullinated peptide, right? Everything we know. Which is going to cause damage in the joint space. Autoimmune mediated damage. So what you're going to see in microscopy? Lymphocytes, plasma cells, rich in the synovium. That's all. Done. Rheumatoid arthritis is entirely done because you guys know the base. The base is what you want to learn. Apply that for every goddamn disease on earth. Make your own pathogenesis, make your own notes. Fine? So you're going to understand the pathogenesis same way what we know. It's an autoimmune disorder, so I'll have a genetic risk factor. The genetic risk factor, one of the HLA predisposes, HLA-DR4, kind of increases the risk of rheumatoid arthritis, right? This one. Because of this, there's kind of a break in the tolerance. That's what we have seen everywhere, right? And have acquired factors as well. Acquired are your environmental factors. Smoking, important person. Few infections. Few arthritis, infectious arthritis can kind of predispose to rheumatoid arthritis. Not exactly sure. I know few of them there. So these guys are going to cause few neoantigens. So what is the neoantigen here we are seeing is, what happens is there are few synovial proteins there. Because of smoking or any other risk factor, this synovial protein is going to get damaged, going to produce a neoantigen. That neoantigen is due to a chemical modification of the amino acid called as citrullination. So what happens here is the neoantigen is, there will be an enzymatic modification of the synovial proteins. Enzymatic modification is citrullination. Okay? This happens to synovial proteins. So when this happens to your synovial proteins, I'm going to have a neoantigen, right? Because citrullination is not there in you and me. These people have that. So what my body does is produces antibodies to this citrullinated peptides. That's diagnostic of rheumatoid arthritis, right? So when I have a break in self-tolerance, this is going to give my T cells. This is going to have B cells because they're going to produce autoantibody because of the new antigen. T cells, as usual, acts via Th1 pathway and Th17 pathway. It's the same routine, right? Th17 brings in more and more inflammatory cells. Th1 causes state damage, right? And in B cells, I'm going to have antibodies against the citrullinated peptide. This is diagnostic. This is a very, very specific antibody. Also, due to few altered tolerance, what I'll have is most of the people, the predominant people of rheumatoid arthritis, have something circulating called as rheumatoid factor, which is IgM or an IgA antibody against the Fc portion of immunoglobulin G, right? So they have something called as a rheumatoid factor. So rheumatoid factor is nothing but an IgM or an IgA antibody against, that's very interesting, right? Against Fc portion of immunoglobulin G. It's against an immunoglobulin. I'm having an autoantibody formation, right? So all these guys, I'm going to have an autoreactive T cell population, which is going to go and destroy my joints, which is going to act on the joints, which is going to destroy the entire joints, destroy the synovium. Full force is coming in destroying the synovium. What will synovium do? Compensatory hyperplasia, lots of fibrin, everything happens there, right? I'm going to have this. So let's assume that this was my normal joint. I had a perfect synovium, okay, and a little bit of synovial fluid as well. I have a perfect synovium. Here, when the damage happens, the same joint, the synovium is going to become bigger. Not only bigger, they also kind of become papillary like. They'll have kind of papillary fronts because both of them is going to have the same thing, right? Like in Lego pieces, right? They're just going to have like this. So why they become like this is below that I have lots of lymphoplasmacytic infiltrate. And I have synovial hyperplasia as well, right? So here, what's going to happen in the synovium is there's going to be synovial hyperplasia, just a response to the injury for sure. I'll have a dense lymphoplasmacytic infiltrate as well. Okay, we have dense lymphoplasmacytic infiltrate. We call this guy pannus. Pannus is the one which is seen in rheumatoid arthritis, an important MCQ. I'll tell you the importance of pannus here. We have to validate whatever we read. If you're not able to give reasoning, whatever we are reading is wrong. You know the history of rheumatoid arthritis, right? I'm sure you know that. We're going to do a miracle now here. Let's assume your joint, your phalangeal joint, or your metacarp, something. When I have a joint space, a very tiny joint space, in which the synovium is so much proliferating, I have so tiny joint space, I have synovium like this. A proliferated synovium pannus. So this is one bone surface. Other side also I have a bone surface, right? Because joint. So there also I have a synovium which is undergoing hyperplasia like this. Lots of hyperplasia. They are like this. They are fitted like this. Let's assume the patient sleeps off, night. So slowly everything comes inside. It was like this initially. Perfectly merges. Okay? Nicely merges the entire night. Early morning the patient wakes up. See, this is what is going to happen in your joints between two synovial membrane. Do you think the patient early morning will be able to move this at all? No, right? See, because they are perfectly interlinked like this, they can't move. So what they're going to do? They're going to try the level best and move, 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 right? The symptom of rheumatoid arthritis is an early morning joint stiffness which gets relieved on movement. Early morning joint is stiff because of the pathogenesis pannus. You keep on moving it. It's nothing but lymphoplasmacytes, right? So you keep on moving like this with pain, obviously. The plasma cells will go away. When you keep on moving, what will happen is, it will be still hyperplastic only, but it will become like this. The papillary projection will go away, right? So my movement becomes easier. Perfect? Pannus is the reason for the symptom. Symptom is nothing but a presentation of a pathology. What you're going to read is the pathology. We're going to read the root. What I see in the leaves, that's your symptom and a clinical medicine. I want you to link it. If you don't link, without linking the root, the leaf is nothing, right? You have to link it. I'm just erasing this part. I do it just for diagnosis. This pannus is what gives you symptomatology. Very, very classical symptom of rheumatoid arthritis. And early morning stiffness. It's because of the pannus which has an Lego-like pieces which merges with them, which will be relieved on movement. Very, very classical for rheumatoid arthritis. If you have any of your family members having it, ask